In this series, we are going to discuss stridor. Stridor refers to a high-pitched, coarse, monophonic sound. This is in contrast to other sounds that we may hear during auscultation of the lungs, such as wheezing, which tend to be polyphonic. Stridor is best heard over the anterior neck and signifies an obstruction of a large airway. As would be expected in the case of an obstruction of a large airway, stridor can ultimately represent a life-threatening condition, and in some cases this may require emergency intervention, including with the use of endotracheal intubation, as pictured here, as well as other measures, including racemic epinephrine, as well as other interventions that we will discuss in detail. Pictured below, we have the highest yield conditions that are likely to show up on your USMLE, as well as the pediatric shelf examination. These include Croup, Epiglottitis, Vascular Ring, Laryngomalacia, Retropharyngeal Abscess, foreign body aspiration, as well as some other conditions that we will discuss briefly, including bacterial tracheitis and diphtheria. And really the keys that you want to pick up with in all of these conditions is how to differentiate them from one another, as well as how to work up and manage these conditions. However, before we dive into specific conditions which involve stridor, we first must understand the differences between extrathoracic and intrathoracic stridor, as ultimately distinguishing these two types of stridor can allow us to more easily localize the location of the obstruction. There are several high-yield conditions that we will cover in these modules, which are examples of extrathoracic stridor. These include Laryngomalacia, Croup, Retropharyngeal Abscess, Epiglottitis, and craniofacial anomalies. The key to all of these conditions in which extrathoracic stridor occurs is that they occur in one of two areas. The first area is the supraglottic area. This consists of the nasopharynx, the epiglottis, the larynx, and the false vocal cords. Extrathoracic stridor can also involve the glottic and subglottic area, which extends from the vocal cords to the extrathoracic trachea. And overall, combining these areas together, extrathoracic stridor essentially involves all the structures which are large airways extending all the way from the nasopharynx down past the vocal cords, including the false and true vocal cords, and all the way down to the larynx and the upper portion of the trachea, specifically the first 2 or 3 centimeters before we get into the thoracic cavity. In contrast, in intrathoracic stridor, this is classically going to include conditions such as vascular rings, foreign body aspiration, as well as compression of the large airways, for example by tumors. And in the case of intrathoracic stridor, this is going to involve the area extending from the intrathoracic portion of the trachea, which is essentially the bottom 6 to 9 centimeters of the trachea, approximately from this point downward, all the way down to the main stem bronchi. And this essentially goes up to this portion here, where we branch from the main stem bronchi into the secondary and tertiary bronchi. Part of the reason that we care about where the obstruction is occurring in stridor is because this can ultimately give us clues when we auscultate the lungs. We will now go through some of the characteristic features of inspiratory, expiratory, and biphasic stridor and how this can be influenced by the anatomy and the underlying etiology. In the case of inspiratory stridor, the reason this gets its name is because during inspiration, the stridor is going to be more pronounced than it is during the expiratory phase. Important to note here that this classically is going to occur with an extrathoracic obstruction. The reason for this is that these airways that are outside of the thoracic cavity are going to have a decrease in airway pressure relative to the atmospheric pressure, thus resulting in a collapse of these structures. And therefore, we are much more likely to see inspiratory stridor, or stridor that is more pronounced during the inspiratory phase, in these conditions which involve extrathoracic obstructions, including Laryngomalacia, Croup, Retropharyngeal Abscess, Epiglottitis, and craniofacial anomalies. In contrast, we have cases of expiratory stridor in which during the expiratory phase, stridor is going to be more pronounced than it is during the inspiratory phase. And very high yield to keep in mind that this is going to occur in an intrathoracic obstruction. This is due to the fact that during expiration, there's going to be an increase in intrathoracic pressure, which is ultimately going to lead to a collapse of these large airways. And once again, this is something that we classically see in conditions in which intrathoracic obstruction is going to be at play, including vascular rings, foreign body aspirations, as well as tumors. No discussion of stridor would be complete without an inclusion of biphasic stridor, in which we have both inspiratory and expiratory stridor. In other words, we have stridor during both phases, hence the term biphasic. This is going to occur in the case of a fixed obstruction, regardless of whether this fixed obstruction is intra or extrathoracic. In actual clinical practice, this may vary between the actual phases of inspiration and expiration, depending on the child's respiratory effort in these two phases. However, for examination purposes, you should be able to rely on biphasic stridor as being associated with a fixed obstruction and having a consistent severity of stridor in both inspiration and expiration. In Croup, also known as laryngotracheal bronchitis, our classic patient is going to be a child who is between the ages of 6 months and 3 years. And classically, this child is going to present with a barking or seal-like cough, as well as hoarseness and inspiratory stridor. Depending on the particular patient, they may also present with a low-grade fever, rhinorrhea, which is a runny nose, as well as a history of a preceding upper respiratory infection. This is because the pathophysiology of this condition is typically going to be parainfluenza. However, other less common causes of croup include RSV, rhinovirus, influenza, and adenovirus. And ultimately, croup is going to involve the subglottic airway. This should not be surprising to us because the subglottic airway is consistent with this being an extrathoracic obstruction, which is the reason why this condition is going to result in inspiratory stridor. As we discussed previously in our discussion of extrathoracic obstructions, the subglottic airway is going to extend from the true vocal cords down to the upper 1/3 of the trachea. This is because the initial 2 to 3 centimeters of the trachea as it descends is going to not involve the thoracic cavity up to approximately this point here. Ultimately, consistent with this involvement of the subglottic airway, we're going to have this narrowing of the trachea, as you can see in this schematic. This is what is ultimately going to lead to the extrathoracic obstruction, and classically is going to result in what is referred to as a steeple sign, which we will see in the coming slides on an X-ray. And this is particularly high yield for croup and frequently shows up on examinations. In many cases, croup can be diagnosed clinically as it has a very classic presentation and age range. We should also have these patients on a pulse ox in order to monitor their oxygenation. And ultimately, if there's any ambiguity in terms of the diagnosis, we can get a chest X-ray, which is classically going to show a steeple sign. This steeple sign can be appreciated on the right-hand side of the presentation, where you can see in this chest X-ray that there is clearly this narrowing of the upper trachea. This is consistent with an obstruction of the subglottic airway, which is ultimately going to produce the inspiratory stridor that we see in these patients. In terms of management, we treat croup with the use of dexamethasone, which is a steroid. Additionally, we should also give racemic epinephrine if we see any of the following signs and symptoms. These include having stridor at rest, retractions, agitation, or having cyanosis or pallor. The dexamethasone helps to knock down some of the inflammation that is involving the larynx and the trachea, while the racemic epinephrine helps to open up the bronchi, leading to bronchodilation and improved breathing in these patients. However, we should reserve the racemic epinephrine for any of these cases that we've described below. Moving on to epiglottitis, this is going to present as a child with sudden onset high fever and stridor. These patients may also present with drooling, dysphagia, as well as a muffled voice. The underlying pathophysiology of epiglottitis is most commonly going to be an infection with Haemophilus influenzae type B. It needs to be noted that H. flu type B is normally something that is vaccinated against, and therefore we are classically going to see epiglottitis in an unvaccinated child. And this is something that frequently shows up in examination vignettes. We have a simple illustration here demonstrating epiglottitis with this clearly swollen and inflamed epiglottis. This is ultimately going to lead to an extrathoracic obstruction, thus resulting in stridor. On physical exam, these patients are classically going to present with what is referred to as a tripod position, or tripoding. In tripoding, the patient is going to have their trunk leaning forward, their hands classically in front of them on their knees, and their neck and chin extended upward and backward in order to help open up that airway. Additionally, on x-ray, these patients will classically have a thumbprint sign. This can be appreciated in the x-ray on the right-hand side of the presentation, where this patient clearly has this thumb-like projection here, which is consistent with an inflamed epiglottis. And this is highly suggestive of epiglottitis. The key to managing patients with epiglottitis is to make sure that we prioritize their airway. As always, we must prioritize the A, B, C's of emergency management, and in this case, we should have a very low threshold for the use of endotracheal intubation, as shown in our schematic here. Additionally, all patients with epiglottitis, because we are likely dealing with a case of H. influenza, should receive empiric ceftriaxone as well as vancomycin. And very high yield to keep in mind that we should also ultimately give prophylactic rifampin to any contacts of patients who have epiglottitis. And this use of rifampin in contacts is particularly high yield for examinations. Moving on to the vascular ring, this is going to present in an infant who is less than 1 year old, classically with stridor, and in many cases coughing as well as dysphagia. One key differentiator of the vascular ring clinically relative to some of the other causes of stridor is that the stridor is ultimately going to improve with extension of the neck. This is in contrast to other conditions such as Laryngomalacia as well as epiglottitis, which are not going to improve with such a maneuver. Additionally, and this may often be present in the actual vignette of the patient, if we give this patient steroids in order to knock down inflammation or racemic epinephrine in order to open up the airways, this is going to lead to very minimal or no improvement in the patient's stridor or symptoms. This lack of improvement in response to steroids or racemic epi is due to the fact that vascular rings ultimately represent an abnormal vascular development. This is therefore an anatomic anomaly that is not going to resolve by simply dilating the airways or decreasing inflammation. One classic vascular anomaly that occurs in the case of vascular rings is the double aortic arch, which we will review in the coming slides. And ultimately, because this is a case of abnormal vascular development, this can lead to two different problems in these patients, the first of which is heart defects, and the second of which is compression of the airway and the esophagus, thus leading to stridor. In our patient with normal anatomy of the aorta, trachea, and esophagus, the aorta is going to sit anterior to the trachea, which is going to sit anterior to the esophagus. However, one classic anomaly that occurs in the case of vascular rings is what is referred to as the double aortic arch. In the case of the double aortic arch, there is this vascular connection between the aorta, which essentially causes this straddling of the trachea and esophagus, leading to stridor. However, upon extension of the patient's neck, this vascular ring is going to come further posterior, thus being displaced off of the trachea and esophagus and leading to a relief of the patient's symptoms. And again, this improvement with extension of the neck is highly characteristic of vascular rings on examinations. On physical exam, the patient may have stridor as well as wheezing, and not surprisingly, they may also have a heart murmur as a result of these anomalies, often involving the aorta. Our initial test in these patients should be to get a chest x-ray, which is going to show anterior bowing of the trachea. Additionally, in these patients, we can also get a barium contrast esophagogram. And because we are evaluating these patients for anomalous arteries, it can also be helpful to get a CTA or an MRA. Additionally, given the fact that these patients may have a heart murmur, as well as the potential for cardiac and aortic anomalies, we should also get an echocardiogram in these patients. And ultimately, because this is a structural issue, we're going to manage these patients with surgery. Moving on to Laryngomalacia, this is going to present as an infant with inspiratory stridor in the first days of life. And although this presents in the first days of life, the intensity of this is going to increase until its peak of intensity at 4 to 8 months of age. It also is absolutely essential to note that this stridor is going to worsen when the infant is supine or eating. However, the stridor is going to improve when the infant is upright, prone, or crying. Laryngomalacia is a congenital anomaly in which there is going to be a collapse of supraglottic structures during inspiration. It should be noted that this is an extrathoracic compression, hence the reason why we classically see this. Laryngomalacia is an extrathoracic obstruction, which is why we see collapse of these structures during inspiration, as well as the presence of inspiratory stridor. Here we have a view of a normal epiglottis in a patient if we were to say look down their throat with a laryngoscope, and as you can see, the epiglottis has this characteristic shape and almost looks like lips. There is a deformity in the usual shape of the epiglottis in that it classically has what is referred to as an omega-like shape. Recall from the Greek alphabet that omega is a letter which looks like this, and as you can see in this image, which is taken via laryngoscope, as we are looking into this patient's throat, that this epiglottis has this classic omega-like shape, and this is highly characteristic of laryngomalacia. Laryngomalacia is of course going to have the key clinical features that we described previously, especially with those changes in the severity of the stridor with position changes in the infant. However, our best test in the evaluation of laryngomalacia is going to be the use of a fiber optic laryngoscope, which is ultimately going to reveal that classic omega-shaped epiglottis. Ultimately, our management of patients with laryngomalacia is going to depend on how well the patient is doing. If our patient just has some intermittent stridor and is having normal weight gain, then we can simply continue to observe these patients. However, for infants who have laryngomalacia that is accompanied by GERD, cyanosis, or apnea, then we may need to proceed with an endoscopy in these patients, and in some cases, ultimately, surgical correction. Moving on to the retropharyngeal abscess, this is going to present in a patient who is less than 6 years old with fever, dysphagia, a muffled voice, and stridor. Additionally, these children are going to have difficulty extending their neck or opening their mouth. Also classically, because there is an abscess present and therefore an infection, these patients will classically also present with tender anterior cervical lymphadenopathy. In recognizing patients with retropharyngeal abscesses in exam vignettes, you should definitely look out for the presence of a history of an upper respiratory infection, acute otitis media, or sinusitis, as these initial infections can often set up and ultimately lead to a retropharyngeal abscess. And generally speaking, as with any other abscess, we are going to have Staph aureus as a common culprit, but these retropharyngeal abscesses can also involve group A strep, as well as various anaerobic bacteria. One classic finding to look out for in our patients with retropharyngeal abscesses is the presence of a widened prevertebral space. This can be appreciated in our X-ray on the right-hand side of the presentation, where you can see that this prevertebral space, or space in front of the vertebra, is much wider than we would see in our typical patient, and this is absolutely classic for a retropharyngeal abscess. Therefore, consistent with the fact that we are looking for a widened prevertebral space in our patients with retropharyngeal abscesses, our first test is going to be a lateral X-ray. Ultimately, however, a CT with contrast is going to be our best test in evaluating these patients. How we manage retropharyngeal abscesses is going to depend on how stable our patient is. If the patient is having retractions, cyanosis, and difficulty speaking, which is often going to be the case in these patients on examinations, then we really need to take care of our ABCs and intubate these patients prior to performing surgical drainage of the abscess. If the patient is stable, however, we can simply give these patients empiric antibiotics and then repeat the CT scan with contrast in order to evaluate for the eventual resolution of the abscess. However, even in patients who are stable, if they have worsening of their condition, or if the abscess is at least 2.5 centimeters in diameter, then we really need to perform surgical drainage in these patients in order to prevent further progression and potential compromise of their airway, which can be life-threatening. One absolutely essential condition that we must cover in the context of stridor is the foreign body aspiration, which shows up all the time, not only on the USMLE, but also on your pediatric shelf examination. This is going to present as a child with sudden onset respiratory distress and cyanosis, and classically, they will have unilateral findings, especially unilateral wheezing, and in some cases, stridor. In this case, the stridor is going to be biphasic because it is due to a fixed obstruction. We covered this in more detail in the earlier sections of this module. The pathophysiology, of course, is going to be aspiration, classically of an object that the child is playing with. On X-ray, we will classically see mediastinal shift towards the unaffected side. Additionally, we can get hyperinflation of the affected side. This is in contrast to patients with a pneumothorax, which will classically see deflation of the affected side. And it should be noted that in most cases of foreign body aspiration in children, most objects can actually not be visualized. Notable exceptions to this, however, include metals, including iron, and therefore one classic case of foreign body aspiration is the ingestion of iron tablets, and ultimately these are going to be radiopaque and visible on X-ray. The fact that metals show up as being radiopaque on X-ray can be appreciated in the chest X-ray on the right-hand side of the presentation, where we can clearly see this coin that this child has aspirated, and because it is composed of metal, it shows up rather easily on chest X-ray. And ultimately, we manage these patients with a rigid bronchoscope in order to retrieve the object and relieve these children of this aspiration. While we have focused these modules on some of the highest yield causes of stridor, it should be noted that there are other causes, including bacterial tracheitis. While we have focused our discussions here on the highest yield causes of stridor for examination purposes, there are some other important causes to be aware of. We have, of course, bacterial tracheitis, which is a Staph aureus superinfection that presents following a viral upper respiratory infection. This can present with a severe croup-like cough, which is going to be that barking, coarse cough, and classically this is going to reveal tracheal narrowing on chest X-ray. Another cause of stridor that likes to show up on examinations is diphtheria. This is typically going to be found in patients from developing countries who don't have the benefit of DTaP or Tdap. In other words, these are going to be unvaccinated children. And classically, they are going to present with a gray or dirty white tonsillar pseudomembrane, which can be appreciated in our clinical image here on the right-hand side of the presentation. That'll do it for now in our discussion of stridor. This is BoardsMD, and this is stridor.